So, good evening, all. I wanted to welcome you to the first webinar for BJAN for this year, 2025. And well, the subject is quite interesting. These are the challenges to improve surgical outcomes. My name is Liana M.T.A. I currently am the chief editor of BJAN. And for this evening, we have, well, we're very honored to call in Dr. André Prato Schmidt and Dr. Luciana Paula Cadore Stefani. He will be presenting. So I'm just going to introduce Dr. André. Dr. André, he is co-responsible for the training center of the University, Federal University of Rio Grande do Sul. He is a member of the transplant team of the Porto Alegre, associate editor of BJAN, and he was the last editor, or the chief editor of BJAN that I have the honor of succeeding. He's done some excellent work during his leadership. It was key for the publication would advance in the international scientific scenario. So I just wanted to thank you for the trust of your successor, Dr. André. So feel free to present Dr. Luciana. Great. Thank you very much, Professor. Thank you for the invitation and for the chance to participate on the BJAN webinar and having the honor of moderating this event and presenting Professor Luciana Stefani. She is a professor from the Rio Grande do Sul Federal University, member of the editorial center. She's been an associate professor for some time. She contributes amazingly to the magazine, to publication for some time. Currently is the teaching editor of the Clinical Hospital of Porto Alegre, a very important position. And for sure, she is revolutionizing the teaching strategy and research strategy in our institution, and as we all know, one of the biggest names in perioperative medicine, if not the biggest at the time in Brazil, with great publications and really a very solid research line. And today we have the ability to hear a bit of what she has to say, and equally I recommend everyone to pay a lot of attention to what she will be suggesting and recommending during her presentation, approaching the subject matter of challenges and opportunities to improve our post-op outcomes. At the end of her presentation, we'll have some time for discussions, and I ask all audience members to post your questions during the Q&A session. So, at the end of the presentation, I will be reading these questions and we will start our discussion. Please, Professor Dr. Luciana, you have the floor. Thank you. Thank you very much. Liana, thank you, Andre. And I wanted to thank you for the invitation and your work, BJAN's work. Andre has been a great editor that put the magazine on a very elevated standard, and Liana took up this challenge. She's starting, and just those that work deeply on a certain cause, only these folks can understand the great challenge that it is, because really it's a lot of work, and it's a work that requires a lot of responsibility. So I thank you all in the name of the whole society, in the name of every anesthesiologist, because we need BJAN to keep growing, and we really need your work. Having said all that, I am very thankful for being here today, speaking about ideas, exchanging ideas. Our goal isn't to provide pathways that don't have a way back. We're just reflecting on what has been in the literature when it comes to perioperative care, and really thinking about how we can, within our great country, our very large country, think about common paths for us to make perioperative medicine a priority, a political priority. This is our cover for this month's BJAN. This was a special edition this month of perioperative. They made a really cool cover for the publication for the magazine. There's several very interesting papers here. I ask everybody to really pay attention to the preparatory materials. The next one will be about PBM. So we're going to have several very interesting additions this year. Well, in this line of thinking, I'm going to be talking about four concepts that I believe to be very valid for us to reflect upon a little bit. First, recognizing perioperative care as a public health issue. Then we we ask ourselves, are we asking the right questions when it comes to perioperative care? And I'm going to be talking a bit about the systems that we must develop and how we use the information that we manage to obtain with surveys and research to improve the care for our patients. So if we think about the surgical system, why we can easily say that really preparatory care must be part of public health policies for improving the public health system as a whole. It's because surgery is very common. We're gonna see that almost 60% of people may go through surgery at some point in their life. Mortality rates after surgery are an issue. They are an issue because mortality rates are high, especially in large high surgeries and high risk patients, much more than intraoperative care. That's old news. We know that transoperatory has been a lot safer the last 20, 30 years. It's rare for patients to pass away during surgery, but it is not rare for them to pass away after surgery. And if we prevent these deaths in 1% of these cases of million surgeries, we'd be avoiding thousands of deaths every year. So, there's new studies showing up regarding the impact of surgery in patients' lives. One of the concepts that we can develop as well is that when a patient goes through surgery, especially a high risk patient, a lot of the time they will never go back to having that baseline level of health that they had before surgery. So people, they go through surgery and they want to be well. We think that getting surgery done is something that will improve, that will solve the problems, and a lot of the time it doesn't. And a lot of the time we get these patients away from their productive life. This becomes a problem, an economic issue as well, and this must be seen. We must have better outcomes so that the economy will be more robust and we continue to have productive people working. So this UK study showed that the risk for people to go through surgery during their lifetime is close to 60%. With the population growing older, you can imagine that the chance of getting surgery becomes higher. And patients that have a post-op complication, they will pass away 2 times higher, more in the next year than patients that do not have complications. So this is a lot of data, but they make us think about how much surgery has an impact on the health system. It's well known for many years, we've been talking about this for years, that if post-op was classified as an illness, as a group of illnesses like cardiovascular disease and so forth, it will be the third cause of death when compared to a more global scale. So, and when we're talking about more specific procedures, or when we start looking at higher risk procedures or higher risk patients, that represents a small portion of the patients that go on surgery. It's not most of them, luckily, but it's the group that complicates the most and is responsible for the largest parcel of deaths and post-op. So laparotomy is a procedure we should look at very carefully. It's a procedure that could be an index procedure in several countries in the world. They use indicators relating to laparotomy, and they develop programs because these are abdominal large-scale surgeries in patients a lot of the time that have a lot of comorbidities, and they go in an urgency situation. There's no time to prepare these people. So there are several reports regarding laparotomy. It's a UK program set up to improve laparotomy outcomes. Since it's been created, the first report of this consortium, the mortality rates was almost 15% in 2012. After this program, mortality rates is around 9 or 10%. In the U.S., a cohort of a DNS skip. It's a large database that they have. The mortality rates are around 14%, and in Sweden, it's around there. In Brazil, we don't have official data regarding this. It's difficult for us to obtain, well, for us to easily obtain data. But we've had a large study done. We have a risk model. We call it XCare BR in 10 hospitals and data that we still have not published. But when we look at the laparotomy procedures on their own, we saw mortality rate that of almost 20%. So this is very alarming data. To have a 20% chance of dying after surgery, this is data that must be looked at very carefully. So we need to ask ourselves, are we asking the right questions in the preparatory stage? Are we looking for the right outcomes? Well, just repeating what happens in developed countries is not enough. We need to look at our reality, at our context, impact. We know that we have a public system. A lot of the times, access is difficult. Patients, a lot of the time, it takes a long time for to go to third-party hospital. Sometimes they arrive in an advanced stage of illness. My patients have health conditions, sanitary conditions that are not good. Post-op recovery can be a lot different from the data we see in the first world in more developed countries. But the concepts of perioperative medicine, they have become more wide-reaching during these last few years. So we already say that pre-op is not just factors relating to the patients. It's not just about them being sicker or not. It really matters the structure that this patient has regarding health. Okay, what was their access? What are the baseline determinants for their health? A lot of the time, the patients they have several difficulties that end up making their health, baseline health, worse on top of all their comorbidities. So, what's their access to the third-party system afterwards? The perioperative processes. It's not just the hospital, but how the processes happen within those institutions. What is the structure that exists there? What's the number of nurses, doctors? How does the systems work? How many beds in the ICU do you have? That all matters for outcomes. Also, there's the associated factors to the patient. Okay, what about the whole load of illnesses that they have, amount of illness they have? The older they are, the more comorbidities they will have, the higher the risk. Then there's the factors that are associated to surgery itself, and anesthesia and perioperative care. So keep in mind early detection with adverse events. This makes a huge difference when it comes to patient outcomes. Post-op is just one stage out of many stages that contribute to these outcomes. So this same paper, it puts down very interesting concepts. Perioperative medicine, what are their goals? To guarantee high quality recovery, reducing disabilities. We're talking about reducing dependencies. These patients that have lowered productivity, avoiding adverse events and mortality rates, optimizing the available resources to avoid unnecessary tests and interventions, promoting safer and more rational care. So here we have several components for pre and post operative care. So even though these concepts apply to all surgical patients, high risk patients are the ones that benefit the most. A more wide reaching approach. So preoperative assessment situations, we need to, especially in these higher risk patients, we need to transform into pre-operative optimization. It's clear that there are factors that can be modified and there are ones that we cannot modify, but well, there is always a opportunity to change, and having this knowledge makes it easier and to have for sure. In developing countries, we are far behind developed countries relating to this optimization. Here we see that this same paper it puts down the stages of the journey of the surgical patient. So intraoperative care, it looks like an intermediate stage of the whole trip, and that may be where we dedicate most efforts, and that's our day-to-day situation. But we need to make this more wide-reaching. We need to understand that it's a whole pre-operative journey. There's a very long journey in post-op care, which can be torturous depending on the complications that the patient will have. We also need to ask ourselves, well, do we know what the interventions are that have an impact on the young? So there's a list of well, a paper that listed several interventions in the post-op care, a few interventions in the pre-control of comorbidities, optimization of anemia, promoting a healthy lifestyle pre-rehabilitation, shared decisions in the perioperative care. How far away are we from working with patients, with their family members in a multidisciplinary team, and a lot of the time deciding not to get surgery done, having other treatments for the patient? This is far more advanced in developed countries, and we're still taking baby steps. When we look at the research when it comes to the preoperative optimization, this paper, you look to identify the amount of publications when it comes to preoperative publications. You can see that the size of the country, the contribution of the country regarding the publications. You can see here that in the global south, we have very little evidence when it comes to preoperative optimization. This is important because this optimization depends a lot on the context of the health system. So we need to understand that we need to look to these priorities. We as a society, we need to ask ourselves, what are our priorities? What are Brazil's priorities? Several countries are working and are defining their research priorities that are and continuously will be the investment priorities in the health systems. For instance, Canada, they have 10 priorities for perioperative care. Well, it's small here, but their priorities, the first priority, for instance, is that factors that are responsible for the satisfaction of patients. Second priority, and when it comes to sharing decisions, you can see the priorities that for us may not be our priorities. In Africa, oh, there's a lot of priorities regarding the development of safe assistance, early detection of hemorrhage, peripartum hemorrhage in Africa is a huge problem. Maternal mortality. In the UK, and priorities that this study shows, these are regarding intensive therapy. These are very punctual priorities regarding cognitive deficit and inflammatory response. You can see that the things are different depending on the context. This other study had a survey done regarding priorities in perioperative care, but as respondents from low-income and high-income countries, and we saw here that post-op care is one of the biggest priorities in developing countries. I think that we need to reflect on this. Where do we want to reach? Where do we start? Our data is, well, our country is a huge continent. There's a lot of inequalities on every index, so the volume of procedures is very different regarding the regions. The number of doctors is very different regarding the region, different mortality rates. We have access to very different procedures. So to look for an increase in inequality in the regions is very important because we cannot focus our efforts and only in a certain regions of the country. And then we have some important data coming up when it comes to our country. For instance, a study from Professor Leandro de Botocatu. He did a study that showed a reduction in cardiac arrest, intraoperative cardiac arrest. Very good piece of research. First big study, big trial that showed this. We can actually start to compare to international data and factors here that are associated to cardiac intraoperative cardiac arrest, extreme emergency surgery is always an issue. Emergency surgery, few specialties. So, as I had commented, we did a study where we validated the risk model in 10 hospitals. We had a number of 107,000 patients. So we have a robust national model that keeps in mind four factors. Today we have the type of hospital, the classification, the age of the patient, the type of surgery, if it's elective or not, and the surgery's name, which is classified as a large-scale surgery or not large-scale surgery. So that's why we must define the large risk patients, at least in the extremes of high risk patients, very high risk patients. We can identify them, and this gives us the chance because so that we can share with perioperative surgeons that we are seeing a high risk patient and that we must then be careful, have specific type of care, and look at this patient in a different manner. In our publication, this edition of BJAN, we published articles about the pandemic. They speak about perioperative processes. We compared patients operated on before the pandemic, around 12,000 patients versus the almost 3,000 patients that were operated upon during the pandemic. And our goal was to identify if the pandemic factor, being in a pandemic, altered perioperative processes, if this impacted mortality rate. We saw that, yes, the pandemic was a factor. It increased the risk of death, even in non-COVID patients. These are patients that were not affected by the COVID illness. The pandemic was such an important factor in the health system. It altered. There was a breaking of these normal processes, and the impact is still within our system. We understand it as a very, very large frailty in our system. Our system must be more robust, must be more responsive to these types of situations. So our third challenge is to develop robust data systems that are connected and accessible. Because what is our need? We need to be able to have data. This data must answer the questions that need to be answered, and this data must be worked on by managers, by the people that work on assistance to improve patient outcomes. This will either be listing data or editorial data or administrative data. The future is that we will have data that can be worked on at the same time as they are being collected, that we may be able to develop models, and these models will be intelligent models that will learn as we input data, and that we can have a closed perioperative cycle regarding risks, management, and outcomes. We are not too close to getting there. We have an issue in Latin America. There are no large systems that can become uniform. Every hospital in Brazil can adopt their own system. There is no regulation for this. There is a program which is the National Health Data Network. The purpose is to establish a national platform with connected data, especially for the base network for third-party hospitals where people can be attended anywhere and their data will be connected. This is ongoing. The speed, well, we don't know a lot about how fast it's going, but this would be the ideal thing in a country like ours for us to have connections, because a lot of the time in the same city, two public health hospitals are different. We not have connected data, and this makes work become repeated, and it's impossible for us to have robust perioperative data if we do not have a central platform. DataSUS provides data for us, but there are difficulties when it comes to access. And so, one of the biggest challenges is still using the information that we do have to improve the quality of care. One of the main needs is that we create value around research around perioperative data. So it's necessary for people to see this as being important for us to know the data. Surgeons must know what is the complications index, the mortality index of their teams. We must know what our complications are. We must know what patients are dying from. We can't just become complacent. We can't not know. We can't not know what is the main cause of death in operations in our institutions. We must look for this information. And this must be seen as important, must be seen as being important by those that work in care, and high-end care must be important for patients or their family members. We almost ask ourselves, okay, what hospital do we want to be operated on? Well, we want to be operated on the hospitals that have the best outcomes. This must be worked on. Managers, clearly, it's important for them to know. But what must be reached? We must reach public policy levels. Perioperative care must be on the agenda. Now, if we go to the Ministry of Health webpage and identify what are the programs, the priority programs of the government, the word surgery, operation, it's not going to be there. There's nothing regarding priorities when it comes to perioperative as a whole. And there's also no priorities when it comes to research programs. There's no grants. We need this to start happening. There's a priority, for instance, in reducing the deaths in surgery. Okay, great. We need to reduce that, but we must reduce surgery lines. But we need to be able to give conditions. Okay, when are parents going to be staying with? How do we reduce these lines if I don't have a compatible number of beds? How are you going to care for these people? Professor Bruce Bickert, he is a researcher, a professor from South Africa. Very innovative. He recently published a book, Safer Surgery for Africa. It's available to purchase. Very good book. It tells stories about patients that have issues in accessing care, stories about mothers that pass away, the difficulties in implementing improvements. We see ourselves in a lot of these situations that are presented in the book. We need to remember that Brazil is not just one Brazil. The private hospital Brazil, we have a lot of differences in Brazil. And he had several implementation researchers studies for attempting to improve implementation, especially for high-risk surgeries. Some of them were not successful when it comes to outcomes. But it's really because of the difficulties that we have when it comes to working with complex systems, as is in a health system. Any improvement will demand continuous work a lot of the time. We're not going to get it right on the first attempt. That's not where we're going to see changes in outcomes. The idea is to identify priorities for patients, systems, hospitals, to work with local data and problem evidence, seeing what is happening, proposing solutions, identifying that these results are important for all, and trying to show the value of these results. And then we're going to be talking once again about perioperative value. A lot of the time, we're not going to be able to, at the first try, to have quantitative data. And to tell the story of perioperative stages is also important. There are several qualitative studies that are helping us to show what is the story of patients, what is their path, why do patients complicate, why is this assistance fragmented, and what can be modified. As 2022 studies identified the barriers to the quality of perioperative care in low middle income countries. And Brazil was not included here. But it showed four main barriers to care. The first is fragmented care and perioperative. We can see it's very similar to Brazil. Limited structural human resources, cost of care for patients. So there's a worldwide problem, which is patients becoming poor when they go to surgery. In Brazil, we have a unified health system. That's not in the agenda, but a patient goes through surgery, they're going to need care that a lot of the time the public health will not be able to provide. Not all cares, not all medications, not all physical therapy, not every single limitation the patient will need to go for, and low general expectations of patients when it comes to care. So, to improve the quality of surgical care and outcomes in patients, it's necessary to work to get over the barriers identified in perioperative care. Once again, we must know what these barriers are. We designed within our institution a care bundle for high-risk patients. We use patients, so high-risk patients. We tested successfully. There's several stages. So it's based on the care of these patients. And there's three. And we don't have ICU beds for every high-risk patient. And they need to be better cared for in nurse and ICU. This is not the rule of vital signs. They are every 8 hours. So we need the vital signs to be seen every 3 hours for 48 hours or more. It seems like we managed to incorporate that the clinical team will see every patient. So we incorporated the co-management. So it's a strategic project in the institution. We managed this because, well, it was a lot of years of work. We also assessed the cost of this care bundle. And we obtained a response that is a cost-effective bundle. We have investment regarding people and the improvement of processes. There's no high cost with interventions or specific monitoring. We saw that patients, well, they costed more when they went into this intensive care bundle because we detected complications more. And patients, we sort of scaled, especially antibiotics, but they passed away less. So in this equation was the cost-effective intervention. So, well, this is a super customized intervention, but implementations must be customized for the environment where they will be adopted. And we will likely not be able to have a transposition for implementation of care in, as it was in Sweden, because likely the care is very different from ours. But there are successful examples in developed countries that we can follow as well. In Australia, for instance, we published this study that proposes a higher risk patient for high risk patients and improvements of patients or patients that deteriorate for the increase, as they call it. It's similar to our fast response teams in the first day, and then a improvement in outcomes. So also the intensive therapy resources is scarce in developed countries. They look for alternatives for post-op there's not just ICU because a lot of times the patients they don't have a indication for the ICU, but they also can't stay at a nursing situation. At the end, I could not mention last week there was the publication of LASIS. It was a very large initiative study in Latin America where they had 17 hospitals, including 17 countries, 280, more than 200 hospitals, more than 1,500 helpers, and where we assessed the outcomes of patients going through surgery. And every hospital collected data for 1 week. In these 284 hospitals, we had 22,000 patients included, and we observed somewhat concerning data. Around 14% of patients go through complications in post-op, and this 14% index is similar to international cohorts. However, 1 out of 7 patients that go through complications passed away after without leaving the hospital. They passed away while in the ICU. So this rate is called a failure to rescue. And this failure to rescue index was much higher than other international cohorts. This NSQIP and this ASOS cohort, we can see the mortality when it comes to complications, and that is the Latin America cohort. It was higher than other cohorts that may be compared to very similar data. So this is concerning data that we now begin to see because, well, what happens in our country, within our continent, and we can have more robust data to begin working in a more widespread manner with more propriety in different instances in the country. I would say that the strategies to improve perioperative care, they go through several stages. Cultural changes might be the most important one. We recognize perioperative care as a public health priority. If we have a robust surgical system, we will have a more robust health system. Identifying that we must collect data, we must research. This data must be integrated to patient care, not necessarily in a academic manner, but we must be curious. We must understand what happens to be able to work in a more accurate manner when it comes to perioperative care. So, customizing post-op pathways. So, everything that is within our reach. It seems that post-op here is where we can act first in a more effective manner, and maybe we still cannot work with preoperative optimization, with rehabilitation, with sharing decisions, and the way more developed countries work. But we can work once the patient goes into the hospital; they are in our hands. We can make it so this patient will have a better pathway. And with that, we'll have a better allocation of resources to define really what patient will have a more care and guaranteeing more efficient resources when it comes to structural resources. And what do we expect? We expect to improve the surgical assistance, to improve surgical assistance in Brazil. These are our BJAN networks. Follow them. Our impact factor is 1.7. Thank you, everybody. Thank you very much. Perfect. Luciana, thank you so much for the great presentation. Once again, thank you for the chance of hearing you speak about very important topics. So I'll invite our audience members to post their questions in the Q&A. That's the Q&A resource here in Zoom, right down there. You can post your questions. I'll read the questions to the professor. So while everybody writes down their questions, I'll get started with our discussion, Luciana. First question that I'll ask is about indicators. You're talking about assessing the results. They have an idea of how our patient is being attended through more objective standards. In Brazil, we see that this is still very incipient. We don't even know the mortality rate of most of our hospitals. You yourself showed data, so it's not very accurate. It gives you an idea, but there are parameters that are tough to manage at an institutional level. What would you suggest to start? I have a public institution where nothing's been done yet. I'd say that a good amount of our subs don't have protocols. There's no well established protocols. Where do we start to establish markers beyond assessing mortality in a period of time? What would be your starting strategy to recommend this to Brazilian hospitals? So, good question, Andre, because not even us. We have a large size hospital, well organized. We haven't even been able to meet the indicators of the surgical sector in a way that meets the needs of the whole perioperative sector. So I'd say we need to associate. Anesthesia can't be on its own. We create indicators. That's not going to be working. We need to work as a team. We need to have surgeons on our side. We need to have nursing folks. So we need to have indicators that make sense for everybody so that people will work in the same direction. For instance, certain procedures. That these are procedures that can be important at a worldwide level, but they make more sense in this hospital. Looking at it more in depth, it's a neurological hospital. Let's say international procedures that are utilized for indicators. There's a group called bellwether procedures, which is C-sec, exploratory laparotomy, and hip fractures. So these are procedures that are an index because one of the worldwide indicators is the access to hospitals that have these procedures. So these are more world level indicators. But we need to convince people that it's important to look at mortality rates, it's important to look at complication rates. Sometimes people don't even want to look at it. Of course, we talk about more data relating to our practice. Clearly, oximetry, temperature. Now, it's a difficult area to work on. Patients that need to be reintubated. All this is really difficult because data is not connected. A lot of the time, the anesthesia sheet is not connected to the system, so we do not have a continuity in care. We don't have a continuity in data. I'd say that we need to have the first idea is to create this culture of working as a group, everyone as a team, so that there's a sense that these indicators must be good. So post-op care, it's not an anesthetist patient issue, it's a hospital issue. They're not well treated. There's no reassessment of pain. There is no pain care team, so patients will be treated worse. So this needs to be on the agenda. It needs to be something that we want to look for. And of course, making this IT connected will be the most important thing to work on. We need to have data that can't be assessed just as an audit. We need to have more robust data. Squealer to go from trans-op is important. Have a pre-op connected to the system post-op as well, and we'll then have a connection of data. This demands that anesthesia wants to be a leader, a protagonist. So I want to be in the system, the whole hospital system. Perfect. Well, it's tough. It's tough. It's tougher. And then we can do the whole operation in a certain way. It is uncomfortable. There's a change in routine. People are used to doing their work a certain way. Well, okay. Well, there's also the matter of which strategies to implement to improve results. So You talk a lot about the difficulties that we have in acting in the pre-op, optimizing our patients to get to surgery in a condition. It's not a reality that we have. It's not that accurate. Things have improved during the years in ambulatory care. Things have evolved, but patients in our reality, a lot of the time they don't have ideal access to optimization in their pre-op. They get to surgery, end up releasing them due to the urgency. We end up accepting them. What would you recommend in terms of strategies that modify the impact the most? What do you want to see about this? A hospital that is still starting once again on starting to change, establishing indicators. You talked about that. So, what would be the initial strategies to have a higher results so that we get to a moment as is in the clinical hospital, that you start to establish certain refinement in a few components? Where will we start on this cultural change? I think that there's several pathways. I'm talking about higher risk patients that have more comorbidities, especially a clinical team. Monitoring from a clinical team makes the whole difference. Recently had a visit from a colleague of ours. She's working in Canada, and the service, our leaders, they have the whole pathway when it comes to troponin and in Canada. So their change is to have a perioperative team. They have a team that sees a patient on the ambulatory. So there's patients that stay at a hospital when they are interned. There's a team that will see this patient, and when surgery ends, this team knows the patient. They continue. They've done their optimization, if possible, in the pre-op. So for sure, I think that there's a clinical assessment that is more in depth, and especially in Brazil, we don't have training. Most of the anesthesiologists, they don't have a clinical training that is enough to manage the extremely complex patients that we receive every day. So shared ambulatory, they're important as well. We start in our ambulatory hospital shared with internal medicine at least once a week. It's shared. There's more serious patients. Systems won't allow a very simple pathway. A lot of time we'll lose the time for surgery. We're going to be time sensitive, and a lot of the time we won't get the green light to operate, and we need to operate on the yellow light. So a lot of the time it's an analogy. A lot of times hip fractures is an example. A surgery example that must be operated on less than 48 hours to have better outcomes, and we must have a management of the team so that we can have a minimally more compensated patient that will have less complications. So I think that it will be shared between the teams. It's very important for the high risk patients. There's a protocol. It makes a difference for people to know how to use routines. This is supported as well. Great. And regarding a certain moment of the presentation, you talked about failure to rescue. In terms of implementation of quick response teams for the Brazilian reality, do you consider this as being key for all the hospitals, or would it be one type of hospital that would need to have? It will be relevant for our reality. What's your opinion about quick response teams? We have a question here. I think that quick response teams are key. And there is evidence in different instances that they do reduce mortality rates. And I can't tell you if they must be present in every hospital, but I believe that there's hospitals that have higher surgeries, that have nursing situations that comport more high-risk surgeries that have several comorbidities. A quick response team makes a difference because it creates a culture where there's a certain autonomy for nursing. at least in our hospital, we talk a lot with the nursing team and surgical units. So, with our specific triggers, and they're authorized to call a team that is not the well, that's not the patient team that will be in hospital. So there are triggers that where they can call a team that will solve the problem. And a lot of the time, what they say is that we're kind of borderline. We actually root for those patients to research the trigger and for them to call them in already and to be able to solve the patient's issues. So in our institution, for sure, it's been an implementation, but no way back. At the time, what we had, the team was the team stopped. So if we stop, this can't happen. We need to have an intermediary instance. We need to have a quick response team. We'll get the triggers, and we'll have hospital teams that will circulating in the nursery teams and have the triggers to be able to have a quick response team. So that's how I see it. Another intervention that has been studied in Canada, there's some studies about this, that is the post-op monitoring as a intervention that reduces the return of the patient to the hospital, that reduces complications. A study that was published about this, and now we're increasing a very large study where the patient will get an iPad home and they'll have all their monitoring there. But you know, even with phone calls, keeping the patient informed, it makes a difference. The problem is releasing patients, sending them out, and not having anything back, no hearing back from them. That's hard. Perfect. Okay, we have two questions. One in the chat, another one in the Q&A. Starting with the chat from Professor Liana, I'd like to ask what we would do so there is a balance between the adoption of these protocols based on evidence and the perioperative care that is customized in case of complex surgical patients. That's the question. Well, I'd say that the health system is complex. Any implementation is complex. It needs to be bought by several teams. If we want to change the format for patient care, we're going to have an initial testing phase, and this must be monitored, and it's best if we do this in a controlled manner so we can get indicators like this. And there are experiences that around the world for intensifying care, care bundles. We designed one that adapted to our institution. We have others that are very much focused on detecting sepsis triggers. We know that mortality and the post-op mortality rates infection is the most common situation. Sepsis, there's a lot of situations where the cause of large amount of the deaths, the detection of these patients that are deteriorating are the most important, and to find ways to increase the detection of deterioration, be it for increasing teams, just nursing teams, safer places, and sending intensivist to go and outside the ICU, out of orders as well. There's a line where certain hospitals are adopting. I don't know if I answered, Liana, but yeah, that's it. If you want to, that's our experience for implementation. It was successful in 2019. The pandemic came in, and now we're retaking the whole program for everybody for this intensive care, and that's everywhere. That's how it is everywhere. And when you have an implementation, teams change, hospitals grow. There's new residents every year. They don't know everything that's going on, so we need to train everybody again. And That's how it is. That's how it goes. I don't think there's. I think we can't lose motivation. We need to know what we want. We need to be coordinated with the teams, working as a team, especially with the nursing folks. You know. There's one question from Jean, very interesting. This line, which is about DRPA. So they could help RPA if they were more robust and efficient. What's the RPA, the recuperation? Well, we don't have a lot designed. And I don't know if I don't know how it works in most hospitals. Intermediary units would be nursing and intensive care therapy. In a few places, most there's no contracting for these intermediary units, so there's a big impasse. Either hospitals have an ICU or ESR or a nursing room. Recovery room is not a room that has the same care as a intensive therapy unit. The study I showed are high dependency units. They're units that there's not high complexity. There's no dialysis. Where there those units where there's more care. So I think that yes, I think that this would be a solution, a very interesting solution to keep the patients in a more controlled environment, at least more serious high risk patients. And you don't need to be inside a complex ICU, but it needs to be monitored. It's inside units that are more controlled. That doesn't just depend on our will. In the public health system, there's a lot to do with contracting. So when we put a patient that should be in the ICU, in the operating group, and we put them into mechanical ventilation, the hospital, if there were intensive therapy, it's not, the hospital will not have this return. This bed is not updated as an intensive care bed. So there's also a problem. Patients are inside a recovery room, and the rotation that we must have. These are strategies that we must think about. But I consider, yes, that we have this culture and this possibility. These are intermediate units, and they can have the specific care done that not necessarily is intensive therapy. In the chat, Dr. Mark's comments about accreditation as we could change the global culture of hospitals could make care uniform. What's your opinion, especially a long period of time working as a team, and really seems to have changed the posture a lot when it comes to the accreditation processes were established there. Well, we had a discussion about this in the hospital. Our hospital has accreditation for some time now. It did change the culture of safety. We start work in a different manner. This ends up going into the institution culture. I'm sure when the team comes in for certification ends up. It seems like everybody behaves differently. But the truth is that culture changes. Not everything is sunshine and flowers. There needs to be big changes in some processes, and it's something that is strategic. The institution can have some sort of certification, accreditation. It tends to get better because there'll be standards, care standards that are respected for how people behave in every instance. And the chapters always relating to the surgical area. They're extensive because patients that go through surgery, they are responsible a lot of the time for a large part of the complications in the hospital. So patients generally, the pathway of a surgical patient is very complex in the institution. There are several transfer of care, services of care, so the risk of having adverse events is very high. And with with accreditation, this process of working with these risks. So there are teams that will be monitoring. This all that improves. People need to think that discussing an adverse event, it can't be a punitive event. It's something that must be automatic. We have a problem, let's talk about it. This needs to improve. Don't make it personal. But for sure, there's a care parameter that is something that institutions always keep in mind. These are mortality situations. We need to have this in mind. We can start on our anesthesia service. I mean, there's small outcomes, but we don't want to discuss. Oh, the patient was gonna die anyway. This was gonna happen anyway. But there's always things that can be done. You can always look at the process. It's interesting to analyze the processes, the factors. We're going to be interested regarding the processes and the structure. We always think, we always learn. It needs to be a good thing. One last thing is that we already are over time. Regarding LASIS, it's revolutionary in our medium. A chart that you showed and the differences in mortality rates are concerning in African countries. What is the explanation for this difference? And there's a few ideas, but what is the explanation for this difference? And one of the things that during the first study in the European countries, it's a matter of a lot of controversy regarding the differences in countries in mortality results. You saw in Latin America countries as a whole, there was a comparison among countries. In Brazil, how it is, and in Brazil, in reality, you can find some standard difference in mortality. You can see that the complication rates is similar, but the mortality rates is much higher than it should be. And did you manage to explore this data to be able to reach some conclusion regarding the causes and differences among countries? Good question. Regarding Africa's data, and as in Africa, there was much lower risk patients. They don't even end up having more risk to be operated on. There's a different profile. The patients are higher risk. Maybe that'll explain their failure to rescue. Not every patient that has complications will be able to rescue. And this index talks about the structure when it comes to rescue, and seeing other studies as well that the differences in hospitals makes it so that the complications are treated in a different manner. Have higher indexes than hospitals that have a lower volume of surgeries. It has to do with the structure and process of the institution. Regarding the processes of the country's proposal was also always to have Latin American data. Latin America is very diverse. There's 33 eligible countries. A few countries have political issues, so can't really participate in research. So this came in, and it's never been a purpose. We have a comparison among countries. Very small countries like Guatemala, with their own structure. Brazil is one of the countries that have a continent with public hospitals, with private hospitals, smaller hospitals, and at some point the idea was never to compare mortality rate between countries. First study in Europe that compared this, and this is not a good experience for the authors, and The idea would be to always have Latin American data. This data did not exist before. You have data that is of Latin America that is concerning, and that we need to care of this. We need to treat our patients better. It also was never always a primary objective to identify differences in the healthcare system. We need a more in-depth analysis for this. We need to have enough data to be able to work in processes and improvement proposals and have this being clear. Yeah. To understand better why this happens. What are our weaknesses in the process and structures we can improve? For this, we have qualitative studies. We need to go further in depth. One final question in the Q&A is from Professor Vanessa Carvalho. Objectively, accreditation improves surgical outcomes, and what are the outcomes? That's a good question, Vanessa. We're doing work. We're trying to look at this. There's no evidence that accreditation in an isolated manner. What type of hospital is an accredited hospital? A university hospital. A good index rate of the nurse level per patient. All of this. And there's an evidence seems so that patients have improved outcomes if they're within a structure that is better. In an isolated manner. So, in a combined manner, there's other studies that show that it is positive. That's a good question for us to move forward. Right. Well, we went over time. Thank you so much, Professor. Great class, great discussion, and the amount of time we had for the subject wasn't that enough, but it alerted us to a lot of relevant cultural factors in our country and tried to alert us. I'd like to pass the floor to Professor Liana. I don't know if Liana has any comments. Any other comments? To finish, sorry, our webinar. I just wanted to thank you. I think that Professor Luciana, I think that you went over several points. I think it was a great class for us to receive within the institutions and our perioperative concepts of care for anesthesia as a protagonist, anesthesia as a helper, and this whole process of surgical transit for patients. So it was very cool, very cool. I knew that was going to be really cool, but it was even cooler. Congratulations, and I wanted to thank you once again, and everyone that could be here, the folks that are here, and it was great. Thank you. Leave the invitation open for the next webinars of BJAN, and to thank you all for your presence once more. Be seeing you. Goodbye. Thank you. Thank you all for the invitation. Thank you all for paying attention to at this time, and let's move forward to the next events for SPA in the webinars. Thank you, folks, everyone. Thank you, Andre. Thank you, Liana. Thank you. Good day. Good evening.